Hello everyone. So we have a 24-year-old healthy person previously, but now brought to the emergency department after an accident. Well, he had a roadside accident, and in the emergency department, patient is alert but anxious and diaphoretic, BP low, pulse high, pupils are equally reactive to light, bilateral chest sound are present. Abdomen is distended with rebound tenderness, bowel sound absent, chest issues, rib fractures are there. Then sonography shows a large amount of intraperitoneal fluid, pelvis X-rays negative for fracture. Patient is hypotensive after rapid infusion of 2 liters of intravenous fluid and is taken urgent for laparotomy. Most likely cause of this persistent hypotension is, well, the answer to this question is hepatic laceration. Why this? Why not others? Well, let's learn the basic concept. This patient has most likely hepatic laceration, so-called HL, with blunt abdomen trauma, BAT. Patient has hypotension, BP is persistently low. Chest wall injury is there, right side. Free intraperitoneal fluid is there. Now, the thing is, why it is hepatic laceration, why not other? This is the most common solid organ injured and in BAT, and second best is splenic laceration. Now, you are definitely going to ask me, why not splenic laceration? The reason I'll be telling you a little later on. Well, as of now, we talk about HL. This is likely due to the right-sided 8 and 9th rib fractures. Chest X-ray shows several rib fractures, including the right 8 and 9, and these 2 ribs are overlying the liver. So that is going to, when they get fractured, they are going to cause laceration. Other manifestations of HL are right upper quadrant pain, right shoulder pain due to irritation of the phrenic nerve from the hemorrhage. Okay, well, you can see the laceration. Lovely picture. Let me enlarge it. Now, feature which suggests the likelihood of intra-abdominal injury includes seat belt sign, rebound tenderness, abdominal distension and guarding, and concomitant femur fracture. But now I have a question for you. Write down the answer. What is seat belt sign? What has been mentioned here? Well, the answer is ecchymosis over the abdomen in the pattern of seat belt. You can see classical thing, beautiful picture, seat belt sign. Let me make it clear now and enlarge the picture. You can see much better now. After that, we talk about after primary survey, patient with BAT should be assessed for presence of intra-abdominal organ injury with the bedside fast and for focused assessment with sonography for trauma. This evaluates both the abdomen and pericardium. Hemodynamically unstable patient with positive fast, that means intraperitoneal fluid, should be taken for exploratory laparotomy immediately. Now let's look into other options. Options C and E, duodenal hematoma and pancreatic laceration. These injuries in BAT are literally uncommon. So definitely you'll always like to go. The best is always hepatic laceration. Now they patient with nausea, vomiting, inability to tolerate oral intake, progressive abdominal pain and sepsis. They all together have different type of presentation. Patient with duodenal hematoma may also have evidence of small bowel obstruction. However, neither duodenal hematoma nor pancreatic transaction are commonly associated with free intraperitoneal fluid. Now the option A is splenic infarction. Point to be noted, in the very beginning I told you there can be hepatic laceration or splenic laceration. But here in the option, examiner is very smart. He has changed the language. It is splenic infarction, not laceration. So spleen is the one of the most frequently injured organ during BAT. The result usually leads to laceration, not infarction as has been mentioned in the option. So, splenic infarction commonly present with left-sided abdominal pain with radiation to shoulder, fever and vomiting. Free fluid is not common unless infarct progresses to hemorrhage and rupture. So this option ruled out. Now look into splenic infarction. In the scan, you can see this is the spleen and normal anatomy, and we now the patient in this we have a right shoulder pain. This is known as Kehr sign. Why this is? Why we get it? The Kehr sign is, look, these are the diaphragm and they are phrenic nerves, okay, and the referred pain, the tip of the shoulder from subcapsular hematoma, and this typically we see in the left shoulder is Kehr sign, what we call as, all due to referred pain from the phrenic nerve. Let's look into other option. Option B, urinary bladder rupture can occur during BAT, especially in patient with pelvic fracture, which is not there in our case. Patient commonly present with gross hematuria. There may be evidence of intraperitoneal fluid, but somehow, despite that, significant hemodynamic instability is not common. It can happen, but not common. But definitely, this will happen in pelvic fracture, which is not there in our case. There is a fracture of the ribs, not of the pelvis. Well, this is the beautiful picture of these ruptured bladder. You can see here the rupture of the bladder is there. Let me enlarge the picture for you so that better visibility is there. Look into this rupture. Okay. You can see rupture here also. Yeah. Golden lines to remember. Hepatic laceration is one of the most common solid organ injuries during the blunt abdominal trauma. Common manifestations include hypotension, free intraperitoneal fluid, right upper quadrant pain, bruising, and right shoulder pain due to phrenic nerve irritation, what we call as Kehr sign. We have a 54-year-old man who complains of bitter taste and substernal burning 30 to 40 minutes after meals. The burning is relieved with antacid and worsened by lying supine. Food gets stuck in his chest if he doesn't chew properly. There is unintentional weight loss, significant weight loss. He has a 40-year of smoking history, 40 pack years. Now, what is the most appropriate next step in the management of this patient? Well, before I discuss this question, I want to ask you, what the significance of positive GUAC test in any patient? Write down the answer. Well, the significance of this is bleeding is occurring in the upper GIT above the ligament of Treats. You should know the anatomy, where we talk about. We have a ligament, suspensive ligament of Treats, which unites duodenojejunal flexure to the right crus or diaphragm. So if the bleeding occurs anywhere here or in the stomach, we call as upper GI. If it is below, we call as lower GI. Normally, if the upper GI bleeding occurs, it is black tarry, what we call as melena. It is black, tarry, and very offensive. But in lower GI bleed, it is usually fresh blood is there. Fresh bleeding is there. Well, as far as our question is concerned, the correct answer is D, upper GI endoscopy. Patient presentation is consistent with typical GERD, that is gastroesophageal reflux disease. Okay, why patient need to do endoscopy? For a reason. First of all, the age is 54 year, above 50 year, we always like to go for endoscopy. Bitter taste and substernal burning sensation 30 to 40 minutes after meals. That means the big problem. It has come up to bitter taste. The reflux has come up to the mouth. Burning is leave with antacid and worsened by lying supine that contribute to diagnosis of GERD. Unintentional weight loss. In the past 3 months, it's a fairly large amount of weight loss is there. Dysphagia. Notice that food gets stuck in the chest, and tobacco use. Patient has 40 pack year of smoking. So let us see how we approach a case of GRD in the management. Well, it's a full screen is there, and its font is small. So I'll be showing you this slide in broken form in the next 2 slides, so that I can tell you much better. I can show you much better. So frame 1. We have a symptom consistent with GRD like in our patient. So then you evaluate. Patient age more than 50 years? Yes, our case is a 55 year. Or symptom for more than 5 years? Or cancer risk or alarm symptom? What are the alarm symptoms? I'm going to discuss in the next slide. Yes, perform endoscopy. Like in our case, we got many features which are consistent with. Okay, so we like to go for endoscopy. But if it is not, then simply try with proton pump inhibitor for 2 months. That means indication of doing endoscopy is dependent on whether we need to do, okay, problem is there or not. But in our case, definitely we like to do. But I'm reminding you, if no, then simply give proton pump inhibitor. And if despite giving for 2 months, that's a refractory symptom, then we have to proceed further. And here we have done endoscopy. What finding we are getting in this? So let's talk about this case where refractory symptoms are there. In such cases, switch to different PPI or increase PPI twice daily. Previously, we were giving once daily. Now we have increased the dose or change the other PPI. Symptom control continue. If persist symptom, then you go for endoscopy or esophageal pH monitoring to be done. Okay, this is how what we are going to see. Now let's see other way around where we have these features like in our case, and we have done the endoscopy. In endoscopy, you are getting no esophagitis or esophagitis. If you are getting esophagitis, to treat according to diagnosis, pill esophagitis, Zoringer-Elson syndrome, eosinophilic esophagitis, or Barrett esophagus. If no esophagitis, then you go for investigation, eclasia, gastroparesis, non-acid reflux disease, nocturnal acid breakthrough. They are the other thing that should be taken into consideration. And after that, depending on the clinical situation, you can go for esophageal manometry, impedance testing, or gastric scintigraphy should be done in where we are not getting esophagitis. So this is how you have to approach. Now let us see, we talk about alarm symptom where you wish the physician or treating doctor should be get alerted, melena, that indicate upper GI bleed. Persistent vomiting, hematemesis, weight loss, anemia, dysphagia, ordinophagia. These are all alarming, raising. In the case of GRD, we have to be very, very alert. That means the matter is a serious matter. So we are clear about it, what all to be done, and why, how we have to approach a case of GRD. Let's look into the other option. Esophageal manometry and esophageal pH monitoring. I covered this point. They are to be done not in all cases, only in these cases where we need no esophagitis, and in such cases we have to do this investigation. The point I discussed, I don't think I need to repeat again. Helicobacter pylori stool antigen testing. This can lead to gastric or duodenal ulcer. We are well aware. Testing is indicated in patients with active or past history of peptic ulcer disease. Routine screening and empiric treatment for H. pylori infection may also be considered for patients who have dysphagia but not GERD. Now, I have one question for you. H. pylori can cause which malignancy? Write down the answer. It can lead to gastric mucosa associated increased risk of gastric adenocarcinoma, and MALT lymphoma, low grade B lymphoma is the right answer. Golden line to remember: patient with typical GRD symptom require an upper GI endoscopy if they have alarm symptom like dysphagia, ordinophagia, weight loss, anemia, GI bleed, men over 50 years, or chronic cases more than 5 years of symptom. Increased gastric risk factor like tobacco use. All other patients can receive empiric trial of proton pump millimeter therapy and further evaluation if refractory to therapy. Well, I hope you liked the session. Just to inform you, we have following courses for you. Smart Medicine. There are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading one page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these 3 things are more than enough for your MD, DNB medicine and family medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These 3 are complete in all the aspects. For more detail, you can contact at this number. It's a mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.